Hello everyone, let's begin part 2 of our MSK Radiology series. So we left last time at TFCC, Triangular Fibrocartilaginous Complex. So it is a very difficult topic, but we'll try to explain it as simple as possible. The first thing is, what is TFCC? It is the primary stabilizer and shock absorber of the distal radial ulnar joint. Okay, it is necessary for push-ups and punching. Components of TFCC include, so what we have to remember is, first there is an articular cartilage with two ligaments surrounding it. So first is the triangular fibrocartilage or articular disc, dark on all MR sequence. And then there are volar and dorsal radial ulnar ligaments. Then there is something known as meniscal homologue. So there are one ligament and one tendon, both are ulnar. So ulnar collateral ligament and extensor carpi ulnaris tendon. So for then we move on to TFCC anatomy, right? So first we have to identify the triangular TFCC articular disc. See, this is dark articular disc with two ligaments, dorsal and volar around it. Then we have the meniscal homologue, the tendon sheath, and the ligament, right? The ligament and the tendon sheath. Then there is something known as a space between the cartilage and the meniscal homologue is the pre-styloid recess. Just try to remember it if possible. Then we move on to the axial cut, and we are seeing again the articular disc, the two ligaments surrounding it, the pre-styloid recess, meniscal homologue, the collateral ligament, and the tendon sheath. So it is not as difficult, right? Then we move on to the injuries. So there are different classes of injuries, class 1 and class 2, acute and chronic being more common. So acute injury generally due to fall on extended wrist. The chronic injury, that is class 2, is more common, associated with positive ulnar variance and ulnar impaction, something we'll do later. We'll just uh, re, tell about it later. Central perforations of the TFCC are common in old age. Just a fact, right? Next, we move on to TFCC vasculature and healing. So, as we can see, the blood vessels applying the TFCC here are more on the ulnar side and then go centrally towards the radius. So, any injury that occurs on this side is going to be relatively easy to heal. So, ulnar side of TFCC is vascular and likely to heal, while radial injuries are avascular and likely to heal. Then we go to ulnar variants, just we saw in class 2, that is chronic type of TFCC injury. So first we see what is normal. The neutral part is these two. There is a straight parallel line. Both of the distal ends of the radius and ulna are in straight line. Now we see that the ulna has been pushed distally, impacting over the lunate. So here we can see that the ulna has been pushed distally compared to the radius. This is positive variance. Then we have negative ulnar variance. Here we can see the ulna has been proximally retracted. On the other hand, the radius has been pushed distally. This is known as negative ulnar variance. So it is determined by comparing lengths of radius and ulna. Okay. So first is ulnar impaction syndrome, a type of positive ulnar variance. Okay. So as you can see here, the ulna and the radius are not in a straight line. Ulna has been pushed. There is some edema seen around the lunate. So this is a type of ulnar impaction. The ulna has impacted on the lunate. So distal ulna hits the lunate and causes degeneration, cystic change or geodes, and tears in TFCC, as we saw in chronic TFCC. MRI shows positive ulnar variance with T2 hyperintensity within the ulnar aspect of lunate, minor cortical irregularity, and subchondral cyst, which is not very well appreciated here. Then we have Kienbock or lunate avian. So as we can see, we all can see there is a pathology here which appears hypointense. So this is negative ulnar variance. Again, we can see ulna here, radius here. So this is avian of lunate. Age group is 20 to 40 years. Negative ulnar variance. Signal dropout on T1. Next, we move on to distal radius or disc fractures. So this is something that most of you will be familiar with. Colles fracture, Smith fracture, Barton fracture, Hutchinson or Schoffer fracture. So first is Colles fractures, right? Okay, first we have to identify the dorsal and volar part. So this is the dorsal part, this is the volar part. So there is dorsal shift of the distal fracture segment, right? So this is distal metaphysis fracture, which is extra articular. This is dorsal angulation of the distal fracture segment. This is also known as Jenner-Folk deformity. So remember from CED, Colles, Jenner-Folk, old ladies fracture, DEXA scan can be done. Common association is ulnar scalloid fracture. Next, we move on to Smith fracture, right? So Smith fracture is reverse Colles fracture. Again, first we have to identify this is the volar side, this is the dorsal side, since we can see thumb here. Right, so reverse Colles, this is also known as reverse Colles fracture. Again, distal metaphysis, extra-articular fracture with volar angulation, also associated with ulnar fracture. If the Smith fracture occurs intra-articular, it is known as reverse Barton. Then there is Barton fracture. So as you can see, Barton is an intra-articular fracture with dorsal radial intra-articular fracture, dorsal type. So if it is volar type, it is known as reverse Barton. So here we saw there is volar angulation. Reverse Barton is also going to have volar angulation. So radial carpal dislocation is the hallmark. Again, if it is an intra-articular fracture, it is kind of obvious. The treatment is surgical repair, high rate of redislocation and malunion. Next, we go to Hutchinson or Schoffer fracture. So here we see styloid process of radius fracture, intra-articular fracture of radial styloid associated with scapholunate dissociation. Makes sense? Intra-articular fractures are going to cause dislocation of the carpals and perilunate dislocation. Next, we have radial tilt. Not a very important topic, so we are going to make two lines like this, and we are going to have to take the angle. Normal is 15 to 25, or around 11 degrees is normal, right? Radial inclination, measured in true lateral. Nothing very important. So wrist tendon rupture or EPL rupture. So we saw lots of radial fractures before just right now. So what happens is once there is a radial fracture, there is going to be irregular morphology of dorsal tubercle of Lister. Okay, so this irregular morphology is going, what is this is going to cause is going to become rough and scratchy and lead to rupture of extensor pollicis longus tendon, which is just adjacent to it, right? So here we see the first we see the dorsal tubercle of Lister. This is the second compartment, this is the third compartment, and just in the third compartment there is edema around the tendon. Which tendon? Extensor pollicis longus tendon, right? So generally more common with non-displaced fractures. So here we also see the tendon that has retracted and there is edema around the tendon tract. Okay. So coronal FATSAT proton density image demonstrating proximally retracted torn tendon with fluid along the rupture tract. On the other hand, on axial image, we can see at the level of Lister's tubercle a completely disrupted extensor pollicis longus with fluid cliff around the rupture site. Okay. So wrist tendon rupture 3 weeks after radial fracture due to it becoming rough and tendon getting friction repeatedly. So then we have wrist tendon anatomy. This is very important. First, we have to identify the dorsal tubercle of Lister. Once we identify the dorsal tubercle, we can see third and second compartment are adjacent to it. So the first compartment is here. So first compartment is made up of extensor pollicis brevis and abductor pollicis longus. Just we saw extensor pollicis longus rupture, so it is the third compartment here. So first compartment, third compartment. First compartment is associated with decubitant tenosynovitis, as we'll see later in this lecture. Then we have second compartment is extensor carpi radialis longus and brevis. Again, there is a syndrome known as intersection syndrome that we'll see here involving this. Then we have compartment 4, which has extensor digitorum and indicis. Compartment 5, extensor digiti minimi. So 4 is for 4 fingers, except the fourth one. Basically, it involves, okay, the fifth is digiti minimi, and 6 is extensor carpi ulnaris, which is involved in RA. Extensor carpi ulnaris, early tenosynovitis, and RA. Next, we go to carpal tunnel anatomy. Okay, so now we just saw the extensor tendons right here. We'll see the dorsal tubercle of Lister. Now we go to carpal tunnel, which is on the flexor aspect, right? So we have 10 structures. It might sound a little bit daunting, but the 10 structures are nothing. It's just 8 are just tendons only. 4 flexor digitorum profundus, flexor digitorum superficialis, 4 each. Then there is flexor pollicis longus, so it covers all the fingers, and there is median nerve. Okay, so one nerve. We all know carpal tunnel syndrome involves median nerve. Okay, so here we have profundus, superficialis, there is tendon of flexor pollicis longus, and there is the median nerve. So here is the guyon canal with ulnar artery and ulnar nerve. Next, we have the carpal tunnel syndrome. So here we can see this is a coronal fats. This is a fat sat MR, right? Fat sat MR, but there is edema around in the carpal tunnel. There is also bowing of the flexor retinaculum. Okay, so median of distribution is involved because median number is involved. Thumb and radial aspect of 4 digit, often bilateral, may have thenar atrophy. On ultrasound, there is enlargement of nerve. Usually occurs due to repetitive trauma associated with dialysis, which is very important risk factor, pregnancy, diabetes, and hypothyroid. There is increased signal in the median nerve and bowing of flexor retinaculum. Right, so this we just saw on fat sat MR, there is edema. Next, we move on to guyon canal syndrome. Right, so guyon canal, again, see now here, this is normal. This is the carpal tunnel, and this is the, on the ulnar side, there is the guyon canal. Entrapment of ulnar nerve as it passes through the guyon's canal, formed by pisiform and hamate, and the fascia that connects them. Generally caused by handlebar injury known as handlebar palsy. Guyon canal syndrome is also known as handlebar palsy associated with fracture of hamate. Here we can see edema in the guyon's canal. Next is subsheath tear or dislocation. So this involves compartment 6, that is extensor carpi ulnaris. Right, we see dorsal tubercular fissure, we see 2, this is 3, we see 1, we see 4, we see 5, and we see 6. So this is 6. So traumatic dislocation of extensor carpi ulnaris, compartment 6 out of its normal groove of distal ulna, dislocation and subluxation. So basically what is happening is the tendon should normally be here. It has shifted towards the medial side. Below, this implies there is rupture of the overlying sheath. Next, we go to Vaughan-Jackson syndrome. So this is a syndrome that is seen in RA. Okay, in rheumatoid arthritis, we have seen that the ulnar-sided tendon flexor carpi ulnaris is involved. Ulnaris is involved, right? We saw we are going back. Sorry, extensor carpi ulnaris is involved. So in RA, multiple ligaments, multiple tendons can be involved from the ulnar side towards the radial side. Okay, so there is sequential tendon ruptures can occur starting from the ulnar side. So compartment 5, 4, 3, 2, right? Compartment 5 is extensor digiti minimi, and this is the sort of deformity you are going to have. Then we have tenosynovitis. So tenosynovitis can be diffuse or focal. Diffuse is can be infective or non-infective. Infective is tubercular or non-tubercular mycobacterial, and the other is rheumatoid arthritis. Focal can be either due to penetrating infection or overuse. The others we are going to see are decoherence tenosynovitis, intersection syndrome, and Tremor's. So we are going to cover each of them now. So the first is diffuse tenosynovitis, tubercular or non-tubercular mycobacterial, and rheumatoid arthritis. So the infection classically involves hands and wrists. There will be diffuse tenosynovitis that spares the muscles, usually in immunocompromised. There can be filling defects in the fluid-filled sheath or rice bodies, which are very classic finding in TB. If you see them, it is TB. So here we can see fluid collections in the sheath, and here we can see rice bodies. Then we have rheumatoid arthritis, multiple flexor tendons or isolated extensor carpi ulnaris. Compartment 6, RA, as we saw, Vaughan-Jackson syndrome, as we saw before, sequential ruptures of tendons, or tenosynovitis can present as an early RA finding before bony finding. So here we can involve extensor carpi ulnaris involvement. Again, we can see tubercular fissure, we can see compartment 2, compartment 3, compartment 4, compartment 5, compartment 6. Next, we go to focal tenosynovitis. Can be due to penetrating infection or overuse. So overuse, if you remember, I mentioned about decoherent tenosynovitis before, which involves the first extensor compartment, which has extensor pollicis brevis, adductor pollicis longus. We are penetrating infection can be focal or diffuse. It is a surgical emergency involving any flexor tendon. So most important is Mycobacterium marinum, which occurs due to direct infection in fisherman and sushi chef. Increased pressure in sheath can cause tendon necrosis and needs immediate treatment. Okay, right hand shows transverse view. Again, tenosynovitis is superficial and deep flexor tendons here. And blue arrow shows carpal tunnel erosion. See, there's a few erosions here. Next, we go to decubitus tenosynovitis, also known as washerwoman sprain or mommy's thumb. Repetitive or overuse injury, as we mentioned before, generally new mom holding a baby. First compartment, we mentioned the muscles, extensor pollicis brevis, abductor pollicis longus. So here there is peritendinous fluid collection seen. Okay, ultrasound, there is increased fluid within the first extensor tendon compartment. MRI shows increased signal, T2 signal in the tendon sheath. A test known as Finkelstein's test, where there is passive flexion of the wrist, as seen here. Pain on passive ulnar deviation, presence or absence of intratendinous septum. Okay, so there is something known as an intratendinous septum, which is sometimes seen on the MR sequence. If the septum is present, it is going to be the grave prognosis. Septum is present between extensor pollicis brevis and abductor tendons, right? Next, we move on to intersection syndrome. So again, I mentioned beforehand, the intersection syndrome involves compartment 2. So extensor carpi radius brevis and longus tenosynovitis, repetitive use injury seen in rovers, occurs where first extensor tendons intersect with the second extensor tendons, right? So basically, first and second compartment intersect. There is overuse of the tendon, causing tenosynovitis or second compartment muscles. Occurs 5 centimeter proximal to listed tubercle. See here. Then there is something known as drummer's wrist, which has tenosynovitis of the third compartment or extensor pollicis longus. We saw EPL rupture, if you remember before, 3 weeks after radial wrist fracture. Now we have there another entity, third compartment tenosynovitis known as drummer's wrist, classically seen in drummers like this. Then there we have Bennett and Rolando fracture. So Bennett is a non-comminuted fracture of base of first metacarpal. On the other hand, Rolando is a comminuted fracture, that is more than 2 fracture fragments. Right. So what is classically asked is pull of abductor pollicis longus tendon is what causes dorsolateral dislocation of the Bennett fracture. So this tendon, after the fracture, this tendon is going to cause the dorsolateral dislocation of the fracture fragment. Then there is something known as gamekeeper's thumb. It is an avulsion fracture of proximal first phalanx. Okay, see here, there is a bony fragment. So that is this causes disruption of ulnar collateral ligament. So what happens is there is another entity known as Stener's lesion. In Stener's lesion, the tendon or abductor tendon aponeurosis. The aponeurosis gets caught between the torn edges of the ulnar collateral ligament. Okay, so here was supposed to be the ulnar collateral ligament that got torn, and then we had the aponeurosis come in between. Okay. There is the appearance is known as yo-yo appearance on MRI. So Stener lesion associated with gamekeeper's thumb. Then another entity, which is the last topic for the day, is trigger finger. Also, an overuse injury or repetitive trauma causes scarring in flexure tendon sheath. So there is a pulley known as A1 pulley at the level of metacarpophalangeal joint. So there is going to be scarring here. This is also known as stenosing tenosynovitis, usually seen on ultrasound. So see, there is thickening of the A1 pulley here. So pulley at base of each digit where the digit meets the palm. So thickening of flexor tendon sheath and tendon specifically at the level of third finger. Mid diaphysis proximal phalanx and the A1 pulley is seen, which causes stenosing tenosynovitis of the flexor tendon. So I hope you enjoyed the lecture. Be prepared for more. There will be around 10 videos of the MSK series. Thank you for being with me. Kindly subscribe, and any feedback is appreciated. Thank you so much.